Welcome back everybody. So in this video we are going to now apply the things that we talked about in the last video in terms of the concepts, and we're going to actually do some math. There's not a ton of math and equations that you need to know for these exams. However, there is some, and I think this is probably one of the most commonly asked about things that you're asked to essentially calculate or use numbers to determine the pathophysiologic state. So let's jump right in. Looking at example 1 here, you can see that the pH is 7.31, the bicarb is 28 milliequivalents per liter, and the PCO2 is 48 millimeters of mercury. The PCO2 is just indicating the partial pressure of carbon dioxide in the blood. So let's go through our steps. Let's start over here, and first we're going to assess the pH. Is it acidic or is it alkalotic? Remember, we said our normal reference range was approximately 7.35 to 7.45, and thus we can see that this is below 7.35, and thus it's acidic. The next thing that we're going to do is to assess our bicarb and our PCO2. So at this point, I think we need to set up kind of our equation, if you will. You can also do this as the first step. So I think the best way to set this up is to say pH equals bicarb over CO2, and to remember that while there are a range of normal values, for simplification and in order to get your questions right, the two numbers I want you to remember is 24 for bicarb and 40 for CO2. So we can set those equal in our equation. And so now we're going to look at each one individually and say, is this above or is this below the expected value that we would expect to see in a physiologic homeostasis? If it's not, then that's going to indicate what is the primary problem that we have. And that's step number 3, is to assess what is the primary disorder that is occurring. So step 3 is to determine the primary disorder. So if this is our normal equation, we can see that for our patient, we have a pH of 7.31 and a bicarb of 28 with a PCO2 of 48. So the first thing I think that you should do here is to assign arrows to the value and say, is this an elevated level or is this a low value? We've already done one. For the pH, we said that this is decreased, so we can put a down arrow next to 7.31. For bicarbonate, we see that the 28 is actually higher than the approximate 24 that we'd expect to see, so this is increased. And then the PCO2 is also increased because we expect a normal value to be around 40, and our patient has a 48. So once we've assigned the arrows, the next thing that we can do is actually assign the primary disorder and say which of these can actually cause the patient's presentation. The patient has an acidic pH, so which of these is going to cause an acidic pH? Could it be the bicarb elevation to 28? This doesn't seem likely because an elevation in bicarbonate would actually cause an increase in our pH, which is not what this patient sees. However, if we look down at their PCO2 and we see that 48, which is an elevated level compared to the 40 that we're expected to see, this means that the patient is actually retaining CO2. And if they're retaining CO2, they're actually forming more protons, more hydrogen protons in the body, and thus causing acidosis. So this being the primary disorder is what makes sense for this particular patient's presentation. And thus, because we have a respiratory acidosis going on, the body is increasing its bicarbonate as a compensation to try and balance this out. So we would say that this patient has a respiratory acidosis with a metabolic compensation. Two key points I want to highlight here. One is that because this patient does not have a metabolic acidosis, we don't necessarily need to go on to steps 4 and 5 for this particular equation, because at this level what you need to know is how to calculate the anion gap if the patient has a metabolic acidosis, and how to use some of the special formulas such as Winter's formula if they have a metabolic acidosis. But if they don't, if they have something else going on like this patient who has a respiratory acidosis, we don't actually need to take it any further. This gets us to what we need to know for answering a question. Now let's move on to example 2. So we're going to go through the same process as we do on the last one, but I'm going to give you guys a little bit more of a pause to think for yourself. So what's the first thing we can do? It's to set up our equation. Then we want to say, is this acidic or an alkaline pH? We know that this is below 7.35, so this is also acidic. We also want to assign arrows to the different numbers. So we can assign a down arrow to 7.25 because we know this is below our normal range. We can assign a down arrow to bicarbonate up top because we know 11 is below our average of approximately 24. And we can also assign a down arrow to the PCO2 because 24 is below the expected value of 40, which we would expect for the PCO2. So now we've done the first two things. We've assessed the pH, we've assessed the bicarb in the PCO2, and now we need to determine the primary disorder. So this patient is acidic. So which of the following, which change can actually cause an acidic pH in the patient? So first we can look at the top and look at bicarb. Could a decrease in bicarbonate cause an acidic pH in the patient? Yes, absolutely, because we know that bicarb is essentially a compound that is going to create an alkaline pH if we have too much of it. So if we have too little of it, the opposite is going to happen, and that we're going to get an acidic pH. And thus this one makes sense that it's the primary disorder occurring in this patient. You can also look at the PCO2 just to confirm and say, would a decreased PCO2 or a loss of CO2 and thus a loss of protons cause an acidic pH? And the answer is no. That would actually cause an alkaline pH. That would cause the pH to raise. And so because of that, we know that's not the primary disturbance. Rather, that is the compensation that is occurring. Our primary disturbance is the decrease in bicarb, and our compensation is to actually change our ventilation status to alter our PCO2 levels. Something I want to mention here as a key point is that changes in our ventilation levels can occur acutely, as in they can occur rapidly, right? We can hyperventilate or we can hypoventilate essentially on command. However, changes in our bicarbonate levels, which occur at the level of the kidney, is more of a long-term change. Those are things that might take hours or even days to actually change within the body. So there are times then where you can have a respiratory disturbance and it takes a while for the metabolic compensation to catch up. In this case, we have a metabolic disturbance and thus the respiratory rate change where we are likely hyperventilating to offload more CO2 and thus causing our decrease in CO2 is more of an acute or rapid change. And I'm highlighting that up here just so we don't forget about it. So now we've determined the primary disorder here, and that is a metabolic acidosis. So what's next? If we were given serum labs, we would calculate an anion gap and determine what's the actual cause of metabolic acidosis. But in this sample problem, we're not giving that information. So the other thing that we can do in addition to is to use our special formulas, and that is a Winter's formula. And again, what is Winter's formula doing? Winter's formula is assessing the ventilation response by the lungs and saying, is it an appropriate level of a response? If it is, then okay, we have a primary problem and an appropriate response. However, if the PCO2 level is outside of the range we would expect to be normal, that can indicate we have two different metabolic processes going on. This is why it's so important you understand the difference between acidosis and acidemia. Acidosis is a process that can create protons or decrease bicarbonate, but acidemia is the actual overall state. That is to say, you can have multiple processes going on. You can have a process that's causing alkalosis and a process that's causing acidosis, but the overall state can go one way or the other, in which you would have an acidemia or an alkalemia depending on the physiology. So remember from the last lecture, what is Winter's formula? And that's right. It's the PCO2 is equal to 1.5 times the bicarb plus 8 plus or minus 2. That's going to give us a value of what we would expect our PCO2 to be in. So let's go through it. So we have 1.5 times 11, because that's what our bicarbonate is, plus 8 plus or minus 2, which gives us a value of 16.5 plus 8, which equals 24.5 plus or minus 2. And thus our expected range of PCO2 is between 22.5 and 26.5. And so now the question is our actual PCO2 within that range? So if we look at this right here and we compare that to our 24, then the answer is yes, it is. Our PCO2 is within the expected range of what we would think that we would have. Given we have a metabolic acidosis, we have the appropriate amount of respiratory compensation. And that's what we've confirmed by looking at Winter's formula to see what would we expect the value to be and comparing that with the actual value. And because the actual value is within the range of expected values, this patient has a metabolic acidosis with appropriate respiratory compensation. All right, for example, number 3, we see that the pH is 7.15, bicarb is 9, and the PCO2 is 38. So at this point, you know the drill. We're going to set up our equation. We're going to assign arrows. And the first thing we're going to do is say, is this acidic or is this alkalotic? So first we can look at the pH and see that this is also decreased. So step 1 is done. This is acidic. We can then look at the bicarbonate and see that this is lower than the expected 24. So this is also getting a down arrow. And our PCO2 of 38 is also slightly below the 40 value that we're using for our calculations. And thus this is also getting a down arrow. So now the question is, we've assessed the bicarb and we've assessed the CO2, and we say which one is causing the primary disorder? Which one could reasonably be responsible for creating an acidic state in the body to decrease the pH? So similar to the last one, we can look at the bicarb first and see that 9 is quite low. And yes, this can cause an acidic state, right? If we're offloading our bicarb, that is going to cause more acidemia within the body. Then we can look at our PCO2 and say that this is decreased as well. And would we expect a decreased PCO2 to cause an acidic state? No, we would not. we would expect a decreased PCO2 to actually cause an alkalotic state. So it's reasonable to think from the get-go that this is our compensation. This is our compensatory mechanism for our low bicarbonate level. And you can see here we have another metabolic acidosis. So if we were given serum labs, we would calculate the anion gap. In this particular question, we're not. So we say, what else can we do? We can do special formulas such as Winter's formula. So we'll apply that again here. And remember, we said Winter's formula was, good, 1.5 times bicarb plus 8 plus or minus 2. So for this patient, the bicarb is 9. So 1.5 times 9 is 13.5 plus 8 is 21.5 plus or minus 2. So the expected range for this patient is somewhere between 19.5 and 23.5. Now the question is, does this patient have a PCO2 in that expected range with their PCO2 of 38? The answer is no. So this patient has a metabolic acidosis with a respiratory acidosis as well, which I'm highlighting here. This is a little bit tricky because you might be saying, why is this a respiratory acidosis when the PCO2 is below the normal value of 40? Which you're right to think that. However, it's significantly above the expected value. We expect it to be in the low 20s for this patient. However, the PCO2 is greatly elevated. So relative to what we expect it to be, this patient does indeed have a respiratory acidosis in addition to their metabolic acidosis, because we are comparing it to what it should be based on the patient's primary disorder. So that's why I said before, there are times when patients can have multiple acid-base disturbances, and we need to calculate to find out which one's the primary cause and if there's appropriate compensation. However, this is why it's so important to recognize that an acid-base process that creates acidosis or alkalosis is different from the total body serum or the acidemia versus alkalemia. This patient clearly has an acidemia because the pH is low. However, you can imagine scenarios where patients can have processes that are causing some acidosis and some alkalosis, and it's about that balance between the two. Which side is having more pull towards the total serum pH? All right, to finish off this video, we're going to go over more of a vignette style of a question. This will be more in line with how you'll be asked on a board exam type of question, where they give you a patient history, some labs, and they expect you to reason out these questions. So here's a really good example of an acid-base type of scenario. So let's go through this question together. First, we have a 55-year-old patient with a past medical history of poorly controlled type 2 diabetes, CKD, and hypertension. So right off the bat, something I'm mindful of that I would highlight is that this patient's conditions are poorly controlled. This means they're either not taking their medications or they don't have access, or there's a variety of reasons, but it's important for us to know that this patient's poorly controlled versus well controlled because it helps us determine our differential going forward. Next, we see that the patient presents to the ED with worsening nausea, abdominal pain, and confusion. Again, in this sentence, I would highlight this patient's presenting symptoms of nausea, abdominal pain, and confusion. Why is that? Because when we think about working up a patient to determine their underlying etiology and their ultimate pathology, we want to think about what makes sense, right? This presentation is making me think of things that are much, much different than if the patient came in with crushing substernal chest pain or if they had back pain. The things I think about with the patient for nausea, abdominal pain, and confusion are much, much different. And that's why it's important to be mindful of what are the presenting signs here. The question then goes on to say that serum labs are obtained and the ABG, or arterial blood gas, shows a pH of 7.27 and a PCO2 of 25. I would highlight those as well, right? We know based on these values that these are things that can indeed be used if this is ultimately an acid-based question. Obviously in this video, we know that it is, but when you're going through practice questions on your own and you're not quite sure, as you're reading through them, you should determine what type of question are they asking me here? Are they asking me an acid-based question? Are they asking me a pharmacology question? And as you do this more and more, you become really good at this skill. So finally, the question says, which of the following is the most likely underlying cause of the patient's presentation? And we're given 4 options: diarrhea, tachypnea, hyperchloremia, and uremia. So the question is, how are we going to go through this? Well, I think we should start with our steps that we've talked about, which is how to determine an acid-base disorder. So first, let's set up our equation like we have been doing. So here you can see I've set our pH of 7.27 equal to our bicarb of 10 over our PCO2 of 25, because we know that's the kind of the standard calculation format that we're going to use for these questions. So what we can do now is assign arrows. Is this above or below our expected values? First, looking at the pH, we can say that this is below what we would expect, right? 7.27 is outside of that normal range of 7.35 to 7.45. Looking at our bicarb, we can also assess this a down arrow, saying that this is outside of our normal range, which as a reminder is what we set up here. We have our approximate pH normal range, and then for bicarb, we want the normal to be about 24, and for PCO2 to be about 40. Yes, this is within a range in actuality, but for simplifying these questions at first to learn the process, this is the best way to do this. And finally, we can see that our PCO2 of 25 is also low compared to our expected normal value of 40. So now we've done the first 2 things. We've assessed the pH, We've assessed the bicarb and the PCO2. And the next thing that we need to do is determine the primary disorder. So same thing as the questions we've done previously, we're going to go through and say which of these makes sense as a primary disturbance. We can look at our bicarb first just because it's on top and see that our bicarb is 10. Well, does it make sense that a low bicarbonate would cause an acidic pH? And the answer should be yes, right? If we have decreased amount of bicarb relative to our protons in our body, that's going to cause an acidic pH. So it's reasonable to think that this is potentially the primary disorder. Next, we can look at the PCO2 of a 25 and say, does it make sense that a PCO2 being low would cause an acidic pH? And the answer should be no. If more CO2 is being exhaled from the body, protons are going to be shifted away in the serum, and this would cause more of an alkaline pH. So this is not consistent with being our primary disorder here. So we say at this point, it's most likely that our bicarb being low is causing a primary disorder, and thus this patient most likely has a metabolic acidosis. So we can check off step number 3, move on to step number 4, which is to calculate the anion gap. And remind me, what is the equation for the anion gap? That's right, it's sodium minus bicarbonate minus chloride. So if we enter our numbers for our patient, we will get 138 minus 10 minus 110, which is equal to 18. And remember, what is our normal range for an anion gap typically? That is up here, a normal anion gap is 8 to 12 milliequivalents per liter. So is this outside of that range? The answer is yes. So this patient has an elevated anion gap metabolic acidosis. This is super important because when we make our differential, one of the key differentiating factors in terms of what's the patient's cause for their presentation, is it a normal gap, sometimes called a non-anion gap metabolic acidosis, or is it an elevated gap metabolic acidosis? This distinction is vitally important. And now we have made it. We have to, this patient has an elevated gap, and thus the things we're thinking about as a cause are going to be different than if a patient had a non-gap metabolic acidosis. And the final thing we're going to do here in step 5 is to assess the compensation, as in, is the compensation or is the PCO2 in the expected range of what we want it to be, right? Because if it is, then that's okay. That's what our body should be doing. However, if it is outside of that expected range, that can indicate we have multiple acid-base problems going on. So let's check with Winter's formula. And remind me again, what is Winter's formula? That's right. It's 1.5 times bicarb plus 8 plus or minus 2. So if we enter in the numbers for our patient, we have 1.5 times 10, which is 15, because that's what their bicarb was, plus 8 equals 23, plus or minus 2 tells us that our range of expected PCO2 is between 21 and 25. Is that consistent with what our patient has? The answer is yes, because our patient has a PCO2 of 25. So this is the expected compensation mechanism. So there we have confirmed that our 25 is indeed our compensation. So that's our final step, is to assess, and we said, yes, the compensation is good. So now to answer the question, we've gone through all of the steps here. We have to go through and say which of these is the best answer, not which of these is a possible answer, but which is the best answer, because that's how they will test you on these questions. So first we can look at diarrhea. We can say, is diarrhea the best answer here? Well, you could be thinking, well, diarrhea is a known cause of decreasing the bicarbonate level in the body, and this patient does have a decreased bicarbonate, so that is reasonable. And you're correct to think that. However, remember this key here when we said we're differentiating causes based on a normal anion gap versus an elevated anion gap. And the key and the reason this is not the best answer is because diarrhea is a cause of a non-elevated or a normal gap metabolic acidosis, which this patient does not have. So right off the bat, we can cross off option A. Option B is tachypnea. Is it reasonable that this patient's tachypnea is the primary disorder? Well, it's not very reasonable, because we said that this is the compensatory mechanism for this patient. If this patient had tachypnea at baseline and that was the primary cause, they would be offloading a bunch of CO2, thus shifting protons away in the serum. This would actually cause a respiratory alkalosis. So we can cross off option B. Option C is hyperchloremia, right? We do have a hyperchloremia, a little bit of 110, right? That's slightly above the normal range. However, is this most likely the cause of the patient's presentation? The answer is no. Again, this comes back to the fact that hyperchloremia is a non-elevated gap metabolic acidosis, and thus we have ruled that out as the primary cause for this patient, because this patient has an elevated anion gap of 18. So C does not seem like it would be the best answer as well. And finally, we have option D, which is uremia, often associated with CKD. Our patient does have CKD. Uremia is also a cause of elevated anion gap metabolic acidosis. Our patient also has an elevated anion gap metabolic acidosis, and thus it makes sense that option D
is indeed the best answer for this particular patient.
So the key with these questions here is to have a process and follow it every single time. I think these are questions that can ultimately become easy for you on test day, and it can really distinguish you as a student in your knowledge compared to other people, because a lot of times we don't want to do math questions. We don't want to think about them, and students might just take a point loss on these questions. But if you begin to follow a system and you practice this application, I want you to get to the point that you're excited to see these questions on test day. When you see an acid-base question, you're like, yes, that's a point for me. Let's do this math really quick and move on. That's where I want you to get. And it takes reviewing and understanding this video, but also continuing to seek out practice problems to improve your skill set. If you understand this principle, you're going to look like an absolute rock star out there. So thanks for joining me on this one, and I'll see you all in the next one.